Hi, good evening, everyone. My name is Dr. Harsha Ramchandani, and I hope you're all enjoying your time for the 7th International Congress on Diabetes. I would like to thank Dr. Dingra for giving me this opportunity to come and present here. Let me go ahead and share my slides. Here it is. So today I'll be speaking on leveraging artificial intelligence to identify and engage high-risk diabetic patients. A little bit about myself. I'm a board certified physician and currently I work as a chief medical officer for Bay Area Community Health. We serve patients in two different counties, which is Alameda County, where there is Oakland Airport near San Francisco, and Santa Clara County, which has San Jose Airport, and a lot of companies are there, which is like Facebook, Apple, Google, and that's called a Silicon Valley. So I thought staying in Silicon Valley, this was the right topic for me to talk about. And last year, we served close to 70,000 patients, and around 15 to 20% of these patients have diabetes. And I graduated or I did my medical school from Gandhi Medical College. I did my MBBS from GMC India, and as well as I did my MD medicine also from the same college. So the learning objective today from this presentation is to be able to identify and describe the commonly used AI tools and applications in the healthcare industry, review the major complications associated with diabetes and their clinical impact. And then the third is how can we combine all of these together as the AI tools and to help manage the diabetes and engage the high risk patients to improve their outcomes. So I'm going to start with the AI tools which we are currently already using in the healthcare in my company or my organization. So first, I want to share that anything that we do in our clinics, we document in the computer system, and it's called as electronic health record. The health record that we use, it's called as Ocean Epic, and a lot of the hospitals use something similar software, and we have the access to see their records as well. So it's a really great platform. We can see each other's note. We can see what patient had done when he went to see another doctor or a consultant, and so forth. And also it helps in not be able to understand the right handwriting of the doctors, as you all know how it is. But it's why that's why the computer systems is very, very helpful for us. So the AI that we use right now is called as DAX Copilot. It's a Microsoft product in combination with Nuance, a company, and it's all HIPAA protected, like patient confidentiality information is there. And this is sort of like an ambient listening device. So when I'm seeing a patient in the room, this device is listening to my conversation with patient, including not just the history part, but also the education that I provide to the patient at the end of the visit, and it documents everything in the computer system. So it saves my time. It helps me spend more time with the patient with the direct patient contact. And there is a YouTube link at the bottom, and the reference is also in all of my slide. But if this is the YouTube link, and if you want to hear more and learn more about this, feel free to click on that link. The next device that we currently are using, it's called as remote patient monitoring. So this is a company that we work with called Kangaroo Health, and they utilize these devices for blood pressure check, continuous glucose monitoring, or simple glucometers, and the weighing machines to give it to our high risk patients. They capture the data from patients, which could be 2 times a day, multiple times a day, and they push it back to our EHR for us to review. They also have nurses and care coordinators that can help engage the high risk patients. The third thing we are using currently is called as the AI Bridge project for the diabetes eye exams or retinopathy pictures. So not just taking the pictures, but also reading the reports is done through the AI. And based on that, we divide the patient as high risk, low risk, or medium risk for the diabetic retinopathy. The other tools which we're currently using is the provider message triage and drafting. So sort of if patient reaches out to us for something, the AI can already respond to that question and draft and response to that. And of course, as a doctor, we just have to review it, change some things if we have to, and then send it out. Again, it saves a lot of time for us. Care messaging is another platform that we use, and it's embedded with our Ocean Epic system, which helps with the automatic text messaging to the patients. So we can do bulk messaging, reminding patients of their care gaps. We can also remind them for their appointments and so forth. And of course, ChatGPT, which we all know, ChatGPT and Microsoft Copilot are other platforms. They're open AI platforms, so be careful. We don't put the patient information on there, but they're very helpful in creating the workflows and other things. So if you've not tried it, please go ahead and use these models. So the second aspect of my presentation is about complications of diabetes. And I know I don't have to spend a lot of time because you're all expert and it's like preaching the choir. And so we all are aware of the major complications of diabetes, can be microvascular, macrovascular, and what are the screening guidelines for the diabetes are listed here as below. The main thing that I want to emphasize is about the healthcare cost. Because of these complications, if they're not taken care of, it leads to the hospitalizations, the other comorbid conditions, and of course, morbidity and mortality. And as per CDC, back in 2022, diabetes and its complication accounted for more than $400 billion in United States. So it's a lot. And so the question is, how can we combine AI to help reduce the healthcare cost and, of course, help improve the patient outcome? So I want to say the disclaimer that this is a work in progress that I'm sharing with all of you. I do not have any results to share at this time, but hopefully by next year, I would love to come back again to this conference to share the results. So what we're planning to do is to take the core clinical data from our electronic health record Epic, which includes labs, history, and physical examination for these points, and medication adherence. The another thing I did not mention earlier, that in our electronic health records, we can see the pharmacy data as well. So if the patient refilled the medication, we can see that. If patient did not refill, we can see that as well. And then we can also see the no-show rates if patient was scheduled to see an eye doctor, the ophthalmologist or podiatrist, or their primary care providers. We can see all of that data. We also can see the ED and the hospitalization. Like if patient ended up in the emergency department or they were admitted for any reasons, it can be captured. It is captured currently in the Epic. And then the last but not the least important part here is the social determinants of health. For example, if patient does not have access to the healthy food, we know it's going to affect their diabetes. If they do not have transportation, they're not going to end up coming to the doctor's office. And if they're uninsured, it causes the increased complication. So we will combine all of these data together to come up with the points. This I'm sharing a real example from my electronic health records for one of my doctor here, and we have already have all the data for different quarters. So we also look at the trend of the data. It's not just one time capturing the data, but also we can trend it through the different quarters and yearly data as well. So how do we operationalize in our EHR? What we're planning to do is use something called slicer, dicer, or reporting workbench to capture all the data, put it in the algorithm. And based on that, we can also come up with different tiers of patients, which I'll show in the next slide. We can use something called best practice advisories, which are sort of like a flag in the chart. As soon as a doctor opens the chart, it shows that patient is a high risk. And please follow up and do this and that. Also the in-basket alerts, which is called as Epic Chat, so we can talk to the team members through this. We are also will be utilizing our remote patient monitoring, our chronic care management, pharmacies, and community health workers to help with this. And of course, using my chart messagings, calls, and text. And we are planning to pilot this in a very small clinic first to see the workflows and refine the workflows and then take it to the next level. So based on all of that, we are planning to have our patients divided into 3 different categories because intervention will also be different for these 3 categories. It's high risk, moderate risk, or medium risk, and the low risk. So in the high risk, they will be receiving the care from the nurses, which are trained diabetic nurses, and they will be outreaching the patient as soon as this is identified within 48 to 72 hours. They will help make all the appointments with their primary care, with their endocrinologist, with the ophthalmologist, and podiatrist. They will be also checking their labs and medications to ensure that all the labs are up to date. If not, they'll be putting the standing orders and tracking or highlighting it to the primary care physicians to follow up. We will be enrolling these patients in remote patient monitoring. There will be a close follow-up from our pharmacist to have a 90-day refill. For these patients, social worker or community health worker will also be allocated to help with the social determinants of health barriers. There will be a diabetes education and primary care physician follow-up every 2 months. For the medium risk, pretty much similar, but with the less intensity. And we want to make sure they have tailored phone outreach, diabetes education. There is a care coordinator who will be helping and monitoring, and there will be primary care physician follow up every 3 months. And then the low risk primary care physician follow up in 3 to 6 months. These are our tactics. If there are missed refills, there will be pharmacy outreach. If there's a neuropathy, we'll have a podiatry visit, footwear education, wound check. If there's a retinopathy, we'll be doing an ophthalmology appointments. The AI bridge, I mentioned about the retina examination through AI and so forth. And currently also we are monitoring the outcomes as you can see in the chart down there, but we will be adding more metrics to this. So finally, our ultimate goal is to see improvement in the clinical outcomes. For example, change in the A1C distribution, reduced emergency department hospitalization rates, slowing their CKD progression, improved medication adherence, increased diabetic retinopathy exams, and increased podiatry visits. Some of the operational metrics include high-risk patients contacted within 72 hours, their remote patient monitoring enrollment rate, and completion of overdue visits or labs. So I hope to see the positive results, and I'll be happy to bring it back to you all next year. But this is my contact information, and this is my email address. So feel free to reach out to me if you have any questions and anything I can help you with. And thank you all for your attention, and continue enjoying this conference. And we'll see you soon next year, hopefully. Thank you.